Right. Hello, everyone. Thank you very much for joining us for our webinar today. My name's Laura Katawaki, and I work for United Way British Columbia, and I have the privilege of being the moderator for the session today. Today, our topic is going to be the CAMH Aging and Mental Health Policy Framework. So we're really excited to provide everyone with an opportunity to learn more about this document. Before we get started with the webinar, I wanted to acknowledge the homelands of the Indigenous peoples of this place we now call Canada and honor the many territorial keepers of the lands on which we work. I am currently working from home today, so I'm on the traditional, ancestral, and unceded territories of the Coquitlam First Nations. And so if we all can take a moment just to reflect on the territories that we're currently on. A few housekeeping items before we get to the presentations. During the webinar, everyone's going to be muted. You're welcome to have your cameras on or off. Feel free to introduce yourself in the chat box, and Ravi, if you can just make sure our chat box is enabled. Ravi's our tech wizard. So feel free when the chat's available to introduce yourself and your organization, and also acknowledge the land that you're on. During our presentations, there's going to be a question period at the end, but throughout the presentations, you'll also be able to put questions into the Q&A box. So feel free to ask questions there during the presentations if you'd like. And as you probably noticed, the webinar is being recorded, and the recording is going to be posted on Healthy Aging Core afterwards, so you'll be able to view it again. And we'll also be sharing, you're also welcome to share it with your networks as well. Now, our presentation today focuses on the CAMH, so the Center for Addictions and Mental Health, Aging and Mental Health Policy Framework. And I was really excited when I was able to read and review this framework. And I really appreciated the fact that it takes a very comprehensive and holistic perspective and lens to mental health. And it looks at not just the medical factors and the medical types of care and services that might be needed to support aging older adults with mental health challenges, but it also looks at the social determinants as well. And I really appreciate the fact that it considered determinants such as ageism, income, social isolation, and loneliness, and many others. And so you'll be able to learn more about this framework in a few minutes. And we'll have the presentation from the presenters on the framework. Then we're going to have an opportunity for some questions from the moderator and also an audience Q&A. And so I'll just briefly introduce our presenters, and then we can get started. And just a reminder for the presenters, if you're not currently presenting, if you can make sure that you're muted. So we have three wonderful presenters today. The first presenter is Rosalind Shields, and she is a senior policy analyst at the Center for Addictions and Mental Health. And in this role, she communicates evidence-informed public policy advice to stakeholders and policymakers through written and oral submissions to governments, policy frameworks, position papers, and strategic relationship building. With a focus on mental health, the social determinants of health, and criminal justice, Rosalind works to advance public policies that are responsive to the needs of people living with mental illness and substance use disorders. She has over 20 years of experience in the mental health field and has held a variety of roles at CAMH, including clinical management, community development, research, and direct service. Rosalind also has an MA in community psychology from Wilfrid Laurier University. Our second presenter is Dr. Tarek Raji. Dr. Raji obtained his MD from the American University of Beirut in Lebanon. He completed residency in general psychiatry at the University of Texas Southwestern Medical Center in Dallas and clinical training in geriatric psychiatry. In 2006, he joined the Center for Addiction and Mental Health and the University of Toronto as a research fellow in geriatric psychiatry. He stayed at CAMH as a clinician scientist and is now a professor of psychiatry at the University of Toronto. Dr. Raji is also a fellow of the Royal College of Physicians and Surgeons of Canada and has a certification in geriatric psychiatry. His research focuses on enhancing cognition in older adults with dementia or who are at risk for dementia using brain stimulation and clinical neurophysiology alone or in combination with other interventions. And he also studies the standardization of care for patients with dementia. And he has held over $22 million in Canadian research funding as a PI or co-PI, and has been involved in a large number of research projects as well as publications. And he also has several leadership roles at CAMH and the University of Toronto. And at CAMH, he served as the Chief of Geriatric Psychiatry, the Chief of Adult Neurodevelopment and Geriatric Psychiatry, and the Deputy Physician-in-Chief for Research. Currently, he serves as chair of the Medical Advisory Committee as of 2023, and at the University of Toronto, he was appointed as the Executive Director of the Toronto Dementia Research Alliance in 2022 and the Director of Geriatric Psychiatry Division in 2022. Our third presenter is Deborah Walco, and she is a member of the senior team of Loft Community Services and is a demonstrated 32-year history of leadership and innovation in community healthcare, fueled by a passion for supporting people to live in the community with health and dignity. For over 30 years, she has been a champion for the rights of older adults and seniors who live with mental illness, substance use challenges, responsive behaviors, and face barriers to social drivers of health. Deborah is committed to creating programs and services that support equitable access to elder care for all and to filling the gaps that older adults and seniors living with these challenges often fall through in our current healthcare system. And so now then, without further ado, I'm going to turn over the floor to our presenters.
Great, thank you. So I'm going to start and I'm going to share my screen, hopefully. Okay, can everybody see that?
Yes.
Perfect. Okay, so thank you so much. Really excited to talk to you all today. So as Laura mentioned, my name is Rosalind Shields and I'm a senior policy analyst at the Center for Addiction and Mental Health in Toronto. And I'm also speaking to you today from Toronto, which is covered by the Toronto Purchase Treaty 13 of 1805 with the Mississaugas of the New Credit. So I'm going to start by providing a high-level overview of some of the challenges and opportunities in aging and mental illness and mental health. And then I'm going to hand it over to my colleagues to talk in more detail about some specific areas of aging and mental health. So since I know we have some attendees from across the country today, I'll just give you a little bit of background about CAMH, where Tarek and I work. And then when we get to Deb's section, she'll give you some information about Loft Community Services. So CAMH is Canada's largest mental health teaching hospital and is one of the world's leading research centers in its field. We have a staff of over 5,000 physicians, clinicians, researchers, educators, and support staff, and we provide clinical care to more than 38,000 patients each year. CAMH also conducts groundbreaking research, provides expert training to healthcare professionals and scientists, develops innovative health promotion and prevention strategies, and advocates on public policy issues with all levels of government. So as part of that advocacy work, CAMH develops public policy positions on a range of mental health and substance use related issues. And one of the ways we do that is through the creation of public policy frameworks. And so these frameworks are high-level, broad-based documents that review evidence, that summarize the current environment, and then propose evidence-based principles to guide public policy in a specific area. And I've included a link below to CAMH's various public policy frameworks and other documents. I can also post it in the chat later if that's easier. So obviously the framework that's going to guide our conversation today is the Aging and Mental Health Policy Framework. And so why did CAMH choose to focus on aging and mental health? Well, first, mental health problems affect a large proportion of the older population. Right now, we know that about 1 in 5 Canadian seniors are living with mental illness or dementia. And that number is expected to increase due to demographic changes, as well as a higher risk of mental illness amongst baby boomers. Also, mental illness and dementia have a significant impact on the quality of life of seniors and their loved ones, and can lead to increased healthcare system costs. So for these reasons, we thought that this was an important area to examine from a public policy perspective. And it's also important to point out that aging and mental health, like most of, actually almost all of our public policy priority areas, was identified by CAMH stakeholders as an important public policy area where they wanted to see us take action. So let's start by taking a really quick look at mental illness in later life. So mental illness in later life can manifest in several ways. Some older adults experience a mental illness, such as depression, anxiety, or substance use disorder for the first time in their later years. Others may have a recurring or ongoing mental illness, but experience new or additional complications as they age. Some older adults experience the behavior and psychological symptoms of dementia, and others face mental illness in conjunction with a physical health condition, with a known correlation. So, for example, Parkinson's disease. The most common, you'll see the most common mental illnesses in later life, the most common is depression, which affects approximately 7% of the older population. However, it's really important to point out that mild depressive symptoms affect about 10 to 15% of older adults, and these can still have significant impact on the quality of life of an older person and their loved ones. Other typical mental illnesses in older adults include anxiety disorders at 4%, and then one that's not on this chart is about 1 to 2% of older adults have aged with a serious and persistent mental illness, such as schizophrenia. The substance use disorders piece is interesting. So less than 1% of older adults have a substance use disorder, and alcohol use disorder is among them, is the most common. However, it's really interesting to point out and important to highlight that more than 13% of older adults report patterns of problematic binge drinking, which presents its own challenges and concerns. So like mental illness at any age, mental illness in later life is the result of a complex interplay of biological, psychological, and psychosocial factors. And awareness of these risk factors assists with prevention, early intervention, and treatment. So while the specifics of these are not going to be the focus of my discussion today, it's important to note that there really are effective evidence-based prevention, intervention, and treatment options for older adults with mental illness, including psychosocial and health and wellness-focused interventions, psychotherapy, and medications. And you'll notice that I haven't specifically addressed dementia in this slide. I'm going to leave that for now because Tarek's going to be speaking to that in more detail. However, in the following slides, when I'm talking about some of the opportunities and challenges, they apply to both adults with mental illness and those with dementia. So while we know that access to prevention, intervention, and treatment can improve the lives of older adults with mental illness or dementia, there are barriers to accessing mental health care. And there are also barriers to accessing the other supports that many older adults with mental illness or dementia also need to live safely and with dignity. So we'll just look at a few of these barriers here. The first is that mental illness is under-recognized and undertreated in older adults. So about 70% of older adults with depression and anxiety do not get the mental health treatment that they need. And part of the reason for that lack of treatment is that depression and other mental illnesses are often overlooked or misdiagnosed in older adults. So for example, older adults with depression often present differently than younger patients with depression. They tend to have more physical complaints, are more likely to withdraw socially, and show problems with self-care than their younger patients. Also, as I had mentioned on the previous slide, depressive symptoms in older adults can be really subtle or mild and not necessarily meet the threshold for an official diagnosis, which means they can be easily overlooked despite the negative impact that it's having on the person's quality of life. So also misdiagnosis can happen because symptoms of one mental illness can be difficult to distinguish from another. For example, both depression and alcohol use disorder can mimic dementia in older populations. And the challenge is that primary care practitioners, who most seniors receive their healthcare from, may not know how mental illness presents in seniors. They haven't necessarily received the training or the skills or the opportunities to build their knowledge. And they're also not always equipped to provide quality care and treatment to older adults with dementia, as well as not having the knowledge or skills to do the identification piece. And this is because older adults with mental illness or dementia have really complex health needs. So one Canadian survey found that 94% of older adults with mental illness also had chronic physical health conditions. And mental illnesses can also exacerbate physical health conditions such as diabetes, hypertension, and cardiovascular disease. And mental illness is also linked to an increase in disability, poor outcomes from physical illnesses, and impairment in social functioning. So to improve access to mental health care for older adults, it's really important that primary care practitioners receive the education, support, and resources to both identify and provide the care to older adults with mental illness and dementia and the complex issues that they're dealing with. And one of the ways to do that is through integrated and collaborative primary health care. And this is where interprofessional care teams work together to address the physical health, mental health, and psychosocial needs of older patients. So another challenge, and I'm sure this is one that you are all more than aware of, is the under-resourcing of home and community care. So we know that the vast majority of older adults with mental illness or dementia want to live in their own homes, but many require home and community care services to do that. And when implemented as intended, home and community care improves the quality of life of older adults and leads to cost savings for governments. Unfortunately, Canada only spends about 1.2% of its GDP on long-term care services. And of that already small amount, only 11% goes to the community care sector, and the other 89% goes to long-term care facilities and hospitals. So this means that many older adults with mental illness and dementia are not getting the sufficient and high-quality home and community care that they need to live safely in their homes. These seniors are either going without this much needed support, which can put them at risk, or the supports are being provided by unpaid family caregivers. And actually, in many cases, the lack of home and community care means that older adults end up stuck in long-term care facilities or hospitals, despite not actually needing that level of care. And this obviously negatively impacts their own health and well-being and is costly for the healthcare system. So we have a clear need for an increased investment in home and community care across Canada, but there's also the need for a redistribution of dollars from long-term care facilities to home and community care as well. So, I mean, that being said, it is important to ensure that the necessary care and supports are available to older adults who want to and can remain living at home, but there will always remain a need for long-term care facilities that can provide residential care to older adults with mental illness and dementia who have physical illnesses or functional impairments. And unfortunately, right now, these facilities are struggling to actually meet the needs of residents with complex needs. A review of Ontario long-term care homes actually found that 90% of residents had some form of cognitive impairment. 86% required extensive help with personal activities, and 50% demonstrated some degree of aggressive behavior. So this puts a strain on an already under-resourced and overworked staff in these long-term care homes who don't have the additional skills and training to care for these vulnerable adults and can lead sometimes to over-medication. So long-term care staff would clearly benefit from additional skills training, but I think, you know, reading the literature and talking to people in the field, what they especially need is timely on-site supports for mental health and behavioral specialists. And we also know that standardizing dementia care in long-term care homes is a promising strategy for addressing complex behaviors and reducing over-medication. And another major challenge that I'm sure, again, is familiar with many of you is the lack of information, supports, and resources for caregivers of older adults with mental illness or dementia. So about 1 in 4 Canadians is caring for someone with a long-term health condition. And those caring for a loved one with dementia spend about 26 hours a week on average providing that care and support. And caring for an older adult with serious mental illness or dementia impacts caregiver quality of life and their health. About 40% of family caregivers of people with dementia have clinically significant depression or anxiety and experience poor physical health. And poor caregiver mental health is linked to long-term care admission for loved ones, as well as an increase in elder abuse. So we know that ensuring timely access to care and supports for the older adults with mental illness or dementia can significantly reduce caregiver stress, particularly when there is access to respite services. But caregivers themselves need their own mental health supports, as well as information and resources to support their loved ones and navigate the health system. So in addition to the system level barriers that I've just reviewed, there are also a variety of health and social inequities that impacts access to care and supports. And these health and social inequities also have an overall impact on older adults' mental health. So we'll just go through these rather quickly. They're in detail in the framework as Laura mentioned, but so ageism and mental health stigma. So experiencing ageism can have a significantly negative impact on older adults' mental health and well-being, and it can lead to depression, anxiety, and general stress. And ageism actually can intersect with mental health stigma. So in this case, older adults and physicians may believe that mental illness is just like a normal part of aging. And this can then create barriers and delays to diagnosis and treatment. Systemic and overt racism and colonial violence can also contribute to and exacerbate mental health problems for older adults who are Indigenous, Black, and racialized, and impact their access to mental health care and other services. So, for example, marginalized older adults may avoid seeking out mental health care due to a mistrust of the mental health care system that is rooted in a history of prejudice and discrimination within Western medicine. And culture and language barriers can create further barriers to mental health care for Indigenous, Black, and racialized older adults. So I'll just give one example here. A lack of culturally appropriate mental health services can discourage Indigenous older adults from actually engaging with mental health care, and partially explain why we found that Indigenous seniors rarely receive formal mental health assessments and evidence-informed treatment. And similar problems exist in home and community care, as well as long-term care for Indigenous older adults. And I really would encourage you to take a look at the racism and colonial section of the Aging and Mental Health Policy Framework. We worked really closely with CAMH's Indigenous program, Shkabi Makwa, on this section, and it provides some more detail on some of the unique challenges experienced by older Indigenous adults with mental illness and dementia, and some of the culturally responsive strategies to improve care and supports for these individuals. I also just want to note it's important that 2S LGBTQ seniors face challenges similar to racialized seniors. Homophobia and transphobia can have a significant impact on mental health and make it difficult for older 2S LGBTQ seniors to feel comfortable engaging in mental health care and other support services or receiving appropriate and welcoming care. Also, poverty and financial hardship and housing insecurity negatively impact older adults' mental health and can actually increase the risk of developing dementia. Poverty affects the ability of older adults with mental illness dementia to access mental health care and supports. So they may not have access to transportation or finances for public transit to attend appointments, or have the resources and supports to help them navigate the complexities of the healthcare system. And they'll also lack the additional funds for private home and community care services that are often needed to complement the underfunded publicly funded services. And finally, social isolation and loneliness, which impact about 30% of older Canadians, have a negative impact on older adults' mental health and well-being, and are linked to increased depressive symptoms, the progression of dementia, and excessive alcohol consumption. And a recent study of seniors' mental health during the pandemic found that those who felt lonely were 5 times more likely to show signs of depression than those who didn't. So we know that there are various barriers to care and supports for older adults with mental illness and dementia, and that social and health inequities not only exacerbate and add additional barriers, but also impact adults' mental health in general. But fortunately, we'll end on a high note here. There are a number of opportunities for improving older adults' mental health, as well as enhancing access to mental health care and other supports that are evidence-informed and culturally relevant. There's also research, policy, and societal level support for mentally healthy aging that can present opportunities for improving older adults' mental health and enhancing access to care and support. So to help put these opportunities into action, CAMH's Aging and Mental Health Policy Framework offers 5 high-level principles. And I'm just noticing here that principles is spelt wrong on this on this slide. So it's principles, but anyway, I will try to overlook that. Anyway, so we have 5 high-level principles, and under each one are more specific recommendations for actions for governments and other decision makers to guide the development of comprehensive policy in the area. So just really high level, the 5 principles state that older adults must have access to evidence-informed mental health treatment, that older adults with mental illness and dementia and their caregivers should receive the care and supports needed to live safely and with dignity in settings of their choosing, that equity, diversity, and inclusion must be embedded in all mental health and dementia treatment, care, and supports for older adults, that policy programs and practices should support mentally healthy aging, and that governments at all levels must prioritize and invest in seniors' mental health and well-being. And because there's a large number of recommendations under each one of these, I'm not going to go into detail with them now, but I really encourage you to check them out for the ones that specifically speak to you and the work that you do and the people you serve, because we do know that with the right mental health care and other supports, that adults with older adults with mental illness and their caregivers really can continue to live their best lives. So with that, I am going to hand it over to Tarek.
Thank you, Rosalind. And Laura, thank you for the introduction. And it's great to be here at it's an exciting event. So I think that there is a lot to talk about when we talk about aging and mental health. And you know, there is 1 hour, 1.5 hours is not going to be enough. So when I was thinking about what to choose from this variety of topics, I thought I would focus my part on the links between aging, mental illness, and dementia. And the reason why I chose that, I mean, because I think there could be some complementarity among the 3 of us, the panelists today, using that approach. But also, I think it's very hard to put aside dementia as we're all getting older, because to this point, you know, we don't really have any treatment that could, or interventions, or that could change the trajectory of an illness. And understanding the links between mental illness and aging and dementia could provide some insight about what we need to be mindful of as we're caring for older people with mental illness, and what are the potential opportunities based on the evidence. I'm starting with this slide, even though it's a little bit older, but it just to highlight the you know, some of the facts that, for example, around the world, and especially in low and middle income countries, every 3 seconds someone is developing dementia. You know, in more higher income, it's every 60 seconds, something like this, 67 seconds. And by the time a dementia manifests itself, it may be too late to intervene. So a lot of the focus, a lot of the efforts is about prevention. And this is, again, where there's something to be mindful of as we are engaging with older adults with mental illnesses. Next, Rosalind, please. So this is some much more recent study from last year. It's a simulation study by the Alzheimer Society of Canada. It's called the landmark study PATH from 2022. And what it shows is us this simulation about where are the numbers in Canada, how many people are expected to have dementia by 2050. So in the And the dark blue bar represents the total number of individuals living with dementia. And the light blue represent what's predicted for new cases, new people developing dementia within each of those years. So you can see that based on where we are now and based on the current treatments and interventions and what we have, we're going to be close to 17,750,000 people living with dementia by 2050. And so it's a huge number. And we're not talking here about early stages of the disease process. So we're not talking about people who have mild cognitive impairment, NCI, which many times precedes dementia. So these are individuals who have functional impairment and loss of independence in certain day-to-day functioning. Next, please. So I use this slide always, again, it's from the same study using the same simulation and predictions to emphasize that with the prediction, to date and in the future, women will continue to have higher rates of dementia than men. That's just the two genders that were focused on in that particular study. And what's also important to be mindful of is that from an equity perspective, is that a lot of women are also caregivers to people who have dementia, and they develop their own cognitive impairment, and it's an added, think about many of those individuals who are caregivers themselves. Next, please. So like I mentioned, I think a lot of the emphasis is on prevention. And this is from 2020. This was a Lancet commission on dementia care and prevention that was published in 2020 that looked at what are some of the potentially modifiable risk factors that if we can modify them, we could prevent dementia cases worldwide. And based on these 12 risk factors, only 12, and we know that there are more risk factors, 40%, so 40% of dementia cases could be prevented if we discover ways to modify the links and the increased risk because of these risk factors. And you can see that these factors cut across the lifespan of us as individuals. So some are related to early life, so low education in early life on its own accounts for 7% of the cases of dementia. Hearing loss in midlife accounts for 8% of dementia cases. So I think, again, when we talk about this percentage, we're talking about that particular risk factor, how much on its own, without the comorbidity that comes with it. Because we know, for example, people who are smoking, they may also be depressed. But smoking on its own accounts for 5% of dementia cases. Depression on its own in late life accounts for 4%. So smoking 5%, and so on. So you can see, a lot of these risk factors, including physical inactivity, air pollution, diabetes, many of those, alcohol, and Rosalind mentioned about the problematic substance use. Many of those factors can be addressed also, not just by quote-unquote medical or pharmacological treatment, but also by lifestyle changes, which are highly influenced by a comorbid mental illness, an existing mental illness in an older person. So to try to implement the lifestyle changes to increase or reduce social isolation, for example, it's a different context, it's a different challenge if someone is suffering from schizophrenia in late life versus someone without mental illness. So to think, part of understanding these risk factors in the context of an existing mental illness is a challenge on its own and requires its own advancement of knowledge as well as development of treatment and interventions. And so among those factors, many of them are linked to mental health, obviously. So not just depression, I would argue, smoking, alcohol use, even the management of obesity or management of diabetes, physical inactivity, all these can be intervened with using mental health strategies. But among those 12 risk factors, only depression makes it among those 12. However, next, please. And it made it to the 12 based on certain cutoffs and certain criteria to make it into that particular analysis. However, we know that really, and that's why I have in the slide, it's one brain to just to think about one place of interaction at the biology level. Really having any mental disorder, any mental illness increases the risk of dementia. So this is from a registry study from New Zealand looking at individuals that was published again last year, looking at individuals who have been hospitalized at one point in their life because of mental illness, and looking at the risk of developing dementia compared to people who don't have that diagnosis based on hospitalization. So the dark colored bars are the percent of individual using the total population of about 1.7 million versus the percent of people who have dementia who don't have mental. So, and you can see it's quite striking, the difference, right, in terms of the percentage. That's taken into account any mental disorder history. If we zoom into the different mental conditions, so next, please. So here what you're seeing are the different percentages that are relative risk here on the x-axis of these graphs. I don't know if you can see the full slide. Is it cut off? No. Back, please go back. Can you see the whole slide? For me, it looks like as if cut off at the bottom. Or can someone tell me? Do you see the bottom of the slide?
I think we do.
Okay, but okay, maybe that's I'll speak to it even if people cannot see it. So here we're looking at the relative risk of any dementia on the top figure with respect to different types of mental disorders in the life, across any time in lifespan. So people who have psychotic disorder, schizophrenia or something related to schizophrenia, they have a 6-time higher risk of developing dementia than the average population. People who have substance use, they're about 5 to 6 higher risk than developing dementia compared to average population. People with mood disorders, so people with depression or bipolar disorder, they are also a little bit less than 5. So you can see, and they have a way to defining neurotic disorder, which that's their definition. That's where they refer to some of the personality-related disorders that they have. And then at the bottom of this slide, what you see is that the risk with respect to what type of dementia, because we know there are many types of dementias, and that having any mental disorder increases the risk of all other forms of then Alzheimer's disease dementia, much higher than Alzheimer's disease dementia, which still it's a much higher risk. We're talking about close to 3 times the average population, 3 times what the average population is at risk at. So clearly there are a lot of, irrespective of the mental health condition, people who have been living with mental illness, many times these illnesses start early in life, and the comorbidities that come with it. And here I'm referring not only about the medical comorbidities, because we know people who have, for example, lifelong schizophrenia, they probably also have poor metabolic management. They may have diabetes. They may have smoked a lot of their times. They've also been subjected to poverty, to homelessness, maybe to abuse, maybe to trauma, and all these could be all contributing towards a lot of social isolation. So a lot of factors, unfortunately, converge along the lives of people living with mental illness to increase further the risk of dementia later in life. Next, please. So what I've showed you so far in a couple of slides before are people who have been hospitalized at one point in their lives. So maybe that could be, one could argue that could be an index of people who have really severe mental illness, irrespective of what the condition is. But this is another study that looked at, again, another population from Denmark here. And then this is looking at people who've had a diagnosis of schizophrenia, irrespective of whether they've been hospitalized or they've been just receiving ambulatory care. And then looking again at the rate of dementia, the cumulative new cases of dementia across the different age brackets compared to people without the diagnosis of schizophrenia. What you can see is that starting around the age of 60 or 65, really people who have, many of them are community without necessarily having been hospitalized, people who have history of schizophrenia, the risk of dementia start to double even more, and that continues to go on into the later decades of life, 70s and 80s. So the link between mental illness and dementia is not only dependent on the severity of the illness, even as an index of maybe milder forms of the illness, the risk is still there. And that's also true when we looked at depression. So next slide, please. So here, what this is showing is the linkage and the relationship between the symptoms of how many symptoms of depression at baseline and the risk of developing mild cognitive impairment. So here it's not even dementia, it's even a stage before dementia. So these are milder forms of maybe depressive symptoms or NCI. Across, this was a follow-up up to six years among more than 2,000 older adults. And you can see a clear relationship between the amount of symptoms at baseline and the risk of developing MCI at follow-up. So really suggesting a mechanistic link that the more symptoms, the higher the risk, that usually that those response, what we refer to it sometimes, those response relationship suggest a causal link between maybe depression and MCI in this case. Next, please. So again, focusing here maybe a bit on more the biology of those relationship. I'm using this example as a model of what could be the mechanism that link depression to dementia, and those mechanisms we're trying still to understand them, and there is some knowledge around them, but I think there's a lot still to learn, and some of those mechanisms apply to other illnesses other than depression. So we know with depression and its comorbidities, there could be an increased stress, which could increase the stress hormones, the glucocorticoids, which could lead to atrophy in certain regions of the brain, like the hippocampus, which is a region that's susceptible to Alzheimer's disease and makes it more, reduces it's the reserve of the brain and makes it more susceptible to developing Alzheimer's disease pathology. But also depression is linked to cerebrovascular disease like strokes or ischemia or milder strokes. And that would also lead to lower reserve and therefore more susceptibility to Alzheimer's pathology, leading to the manifestation of the Alzheimer's disease and maybe lack of compensation, and therefore the manifestation of the syndrome of the loss of dependence and the clinical symptoms of dementia. Next, please. I think that's the last slide. So again, going back to that trajectory of the multiple risk factors and those 12, but even more, as we know, as I showed you, related to many other mental illnesses. So how do we intervene? And to me, I put this slide in a way to think about it also as a matrix that related to what Rosalind, showed you with her last slide in terms of what are the recommendations. So we need to think of comprehensive models of care, comprehensive treatments. We need to think of biological treatment, continue to try to discover, the biological mechanism that link these conditions, so that we can intervene, so that we can discover new medications or new disease-modifying treatment. But also we need to think of psychological interventions, so behavioral interventions that could not just treat the underlying condition sometimes, whether it's through cognitive training or or other forms of behavioral intervention, but also to design lifestyle interventions that could reduce the risk factors, which again could change and influence the biological links between mental illness and neurodegenerative disease. We need to also to think about, as comprehensively about social intervention. So when we think of social isolation as on its own accounting for 4% of dementia cases, that's without taking into account that some people are social isolated, have depression as well. So these things add up. So we need to, when we think of, if we're going to think of dementia prevention models of care, we need to think of as well social interventions and social context for where we deliver, how we deliver those biological and psychological treatments. But also what's important is to, as we're developing models of care, is that it will be probably much more impactful, more synergistic, is that we think of, if we integrate those treatments together, rather than focusing on one intervention at a time, how can we develop things that could integrate so that we can address multiple risk factors using a comprehensive biological, psychological, and social intervention, so that we can have synergistic effect at the individual level, who probably has multiple of those potential modifiable factors. So I'm going to stop here and pass it to Debbie. Thanks.
Thank you so much. Now I'm just going to share my screen. Everyone can see? I can't see anyone, so if tell me if you can't.
No, we can't see your screen.
You can't
right
see
now.
yet? Okay, hang on. Maybe I did it too soon there. I wonder if technically I'm kind of blocked out of sharing. Is that better? There we go. I think it was a timing thing. Can you see that now?
Yes, we can see it.
Excellent. So it's a real pleasure to be here. And I have to tell you, I would say Dr. Raji and I were informal partners like 27 years ago, when I used to be so happy when he would come and provide psychiatry for our clients, and so pleased with working with Rosalind around the framework as well. And so I'm just going to talk a little bit about examples of community kind of services that are provided in an integrated way for all the reasons that both Rosalind and Dr. Raji have been speaking about. When it comes to aging and mental health in the community, there are services that are needed. And it isn't just what the services are, but how they are delivered are just as important to make an impact on older adults' lives in receiving the right mental health and physical health care. So just a couple of slides about LOFT that I will not spend any time on, but I've just included it. So you say, hey, who's this organization, so that you've got it. We do provide service in Ontario from Toronto all the way up to Simcoe, Muskoka, York Region in between. And I would say it's been it's amazing, connecting with a BC-based organization. I know we have people from across the country on the call today, and I was just at a geriatric psychiatry conference on the East Coast, and we're working with an organization on the West Coast that's starting to do this work. So it's really lovely that we can come together nationally to talk about such an important thing. So when you talk, and we've heard some of these things as we've gone through our time together today, but when you talk about supporting those older adults and seniors that are living with mental health, substance use, responsive behaviors, dementia, that sort of thing, there's a lot of considerations that need to be taken into account when you're designing how you provide these services. We've talked about social isolation already today. We've talked about the equity lens, the stigma of mental illness and ageism. You know, traditionally, I've been around long enough to think back, and it's gotten much, much better in our healthcare system across the country. But originally, the focus would always be on the mental illness and the symptoms of that, and not so much about how somebody was managing their diabetes and those sorts of things. And so just as Dr. Raji was talking about, that has a relationship of decreasing health on both fronts. Everyone's on a different journey. Not everyone's going to approach their healthcare in the same way. And that goes for everyone. So meeting people where they are at on their journey. We often talk at Loft about, you know, sometimes, you know, individuals will leave that path that we'd hope they'd take on their healthcare journey and their life journey, but we stick beside them until they get back on the path, and it is their journey. The social determinants of health, the social drivers of health, you can also call it too, which has been talked a lot about, you know, food, housing, education, you know, income and wealth distribution, equitable access, all of those things are so important and really determine outcomes for people. Having trauma-informed care, and I think, you know, there's many seniors, I really have seen this over the year, that had they received the right supports around traumas they'd experienced in their life, they may not be in as much need in later life around mental health and psychosocial supports, because they would have had the right support at the right time. A lot of the seniors we work with have medical trauma, either due to their physical health and their experiences in the healthcare system or the mental health system. You know, if seniors that we're supporting today became ill in their early adulthood, their experience was far different back, you know, many decades ago as to what the system is now. And that creates this disenfranchisement and this disconnection and reluctance sometimes to seek out or participate or be engaged with their own healthcare. And that's a very gentle process that we need to do as service providers, is to respect that and meet people where they're at and really support that connection in their time and kind of space. Our system has been funded, you know, you either get seniors funding or you get mental health and addiction funding or you get other sorts of funding, but they've been in silos. So the systems we're getting there. They're becoming more systems, but the system is siloed based on that funding. So you might have somebody that is receiving support for their geriatric needs, but that provider doesn't have the same connection with mental health and addiction supports, and vice versa. And so it really has that integrated piece that we've been talking about. It really behooves us as service providers to figure that part out. So we always hear, you know, the complex needs that individuals have, that we're meeting complex needs. Well, the system should be equipped to meet complex needs. And, you know, being an older adult and living with a mental health challenge and some psychosocial or social determinant of health needs is really not that complex, but our system hasn't been built that way. And so it really behooves us to figure out how to do this together. And then the shades of gray when it comes to older adults and seniors and supporting them is the different silos that we have in the funding and how we provide service don't always have the expertise around these shades of gray areas. And that comes in when somebody's capacity for decision making is changing. If it's changing because of cognition decline, or is it changing because of the status of their mental health and how they're feeling, or their social determinants of health. And how, you know, each of those silos kind of approach those things in a different way. And unfortunately, for many people, the human beings we serve, it's not always holistic. And so risk is created, things get missed, people are allowed, you know, or go along in their journey without support when they should have had support. And quite honestly, when they have capacity, sometimes we can be a little overbearing in how we provide that support. So we need to focus when we provide services for older adults and seniors living with this in their realm. We need to be focused on several things, working towards that integrated health and social service system. We're a longstanding partner of CAMH, as I've noted, and our models have really evolved together. by bringing kind of an integrated partnership. In the old days, it would be collaboration, like we would work very politely together and draw on each other's strengths. But our newest kind of models of support that we provide are completely integrated. Which is important, because then the individuals we support have this very strong continuum and holistic approach to their support and care. Navigating the health and social service system with a population that has a history of being stigmatized. That system navigation, that care coordination piece, when we do that, we have to do that with team members that are really specially trained in understanding that. And, one of the most common, sadly, and it's happening far less now, but over the years, would be a client that was experiencing pain and was also living with a serious mental illness. And we send them into the emergency department. They'd say, oh, psychiatry has to come and see them. And they were living with this pain, and then they'd get sent back. And then we would send them back to hospital. And I remember some situations 3 and 4 times. And the 4th time, you'd get the right physician, the right triage nurse, whoever it was, that would say, you know what, why don't we check out the pain? And then they'd have a broken hip, perhaps, and that sort of thing, and would be rushed right off to surgery. But that was a fairly common kind of event. And it's that stigma of not looking at the whole person and what they're living with their total health. Ensuring that people get to the right place of care and support in their transitions. So if they're, leaving the emergency department, that they're safe and sound at home, avoiding eviction, discharge to shelter, long-term care, really understanding where people are transitioning to and the help they might need. We have some embedded teams in emergency departments now too, that go beyond the walls of the hospital to kind of check out somebody's apartment and make sure that it's okay. And because it's very stressful for the hospital teams that don't leave the wall. So those mobile kind of teams, either from the hospital or in an integrated way with community hospital, are really important. And I'm going to talk a little bit about ALC transitions and the lessons learned from that, because they really tell us what the issues are. So when we talk about holistic services focus on complexity in elder care and seniors care, you got to think of the social determinants of health. We've said that a lot today. The social drivers of health, I heard at a recent conference as well. Thinking about landlord and tenant considerations, and people cannot take care of their health if they don't have a roof over their head, or if it's not stable. Mental health, substance use, chronic health concerns, dementia, as Dr. Raji has talked about, and integrated behavioral support. So we've really come a long way. Loft is a behavioral support provider here in Ontario, one of them, and having that integrated behavioral supports has really propelled our work ahead to really make it more individualized and look at, behavior has meaning. That's a mantra for us, and really looking at, when there is behavior, what unmet need is there, and how can we create a support plan and a plan of care to address that. So I just included this ALC transition slide. We do a lot of transitions. So ALC is alternative level of care. And Loft has been doing a lot of work over the last decade around transitioning, supporting the transitions of people from hospital who are in an ALC bed, which means that they no longer need acute care, but the right thing out in the community is not there for them to transition out of hospital supported in the right way. And so I included this slide because ALC teaches a lot of what is missing in our system, the things that are not integrated, what we have to do in order to meet the needs of someone who is living in hospital, essentially, and nobody should be living in a hospital. They should be reserved for that great piece of acute care that they do. So it's really about deep understanding of the complex needs of the clients, building on relationships to breed a higher standard of care, so that really tailored service to that person, moving away from rigid targets, timelines, and processes, and talking more generally, because some people, need a little bit less, but some people need a whole lot more. Those tailored efforts and approaches, and innovative and creative support based on the person's needs. So we transitioned about 467 individuals from hospitals in that geography that we served last year. It's obviously, from a system point of view, it's way more economical for the healthcare system. And if you look at the quintuple aim, you know, it's about advancing health equity, reducing costs for sure, but improving population health, enhancing the care experience for the care providers, and the clients receiving care that is meaningful to them and increases the quality and health of their lives. And so those connections, that resilience, you know, anything that supports resilience and the connections and the health and well-being results in a higher quality of life. And those connections are with themselves and with others within sometimes some of the site-based services, as well as the greater community. Having optimal physical health, positive mental health, reducing visits to hospital when not needed, reduce substance use. And then that resilience, like really working on supporting individuals in coping and feeling like they're in control of their life and it's their journey. The self-efficacy, the regulation and hope is a big concept for us at Loft. And I often say we meet so many people that they can't carry the hope. Their experience has been such that it has drifted away. And the happiest times we have is when we carry it for someone and with somebody and able to hand it back when they're ready to take it back. And that's when that connection to community and health and all of those things start to come back. And with older adults and seniors, there sometimes is going to be a decline in health, even with all of that work. But what we found is managing and going through that part of their journey takes on a different energy for them because of this other piece of work and being engaged around their healthcare. And I'm going to, at the end, just share briefly about Brian's story, who's on the right side of the picture there. So there's just a couple of different stories that have been done on individual older adults and seniors that are living with mental health and substance use challenges and dementia, and how they have been able to live successfully in the community and transition well and have a home of their own. Sometimes they're in our high support sites, sometimes they're out in the community, and we spoke out the services. Back to home model is just one example of one of the programs Loft provides to older adults and seniors. And I'm just sharing kind of this broad poster that we had presented. But the reason I highlight that is it includes all of the components. So when you see the social drivers of health, we talked about health and well-being and how important that is, behavior support and life enrichment. That's the service model. And you can see in each of these quadrants the components that we have to meet those needs. I won't go through for the sake of time, but personal support workers, for instance, are the backbone of our site-based services for obvious reasons, right? Care, social support, that sort of thing. Life enrichment is a very big part related to behaviors, connection to people themselves and each other, having housing and food and meaningful social connections, and behavioral support plans when are needed. And just another kind of list, just as an example for people to see the kinds of services that are provided to meet those needs that we've been talking about this whole session. And you look at, we as a community-based mental health and addiction service provider and senior service provider provide the things on the left, and that's where our strengths lie. And you can see what our partners like CAMH provide to create that integrated care. And it ranges from primary care and psychiatry and nursing and infection control, pharmacy, all of those things. And the key success factors is this doesn't just naturally happen. It evolves out of a commitment of the organizations and service providers to commitment to a shared vision where we all agree what's our common goal, and that's the only thing that matters. The rest we can work through. And if our goals are person-centered, tailored services, integrated partnership, and enablers of excellence, these are the mechanisms that allow all of that to happen. And I would say it's got to be the leadership of the organizations that are committed as well as all of the team members right down to the front line, right? And providing the services, because that's how you work out the healthcare continuum issues that sometimes come up. And all provided in a culture of safety, which means it's a just culture. It's a culture of safety for the team members that are providing service and the clients we serve. Oh, Brian's story isn't there. Oh, I'm sorry for that. But in Brian's story, and what I'll do is I'll send in the slide. He tells his story and his journey with his physical health and his mental health care and how that impacted him. So he was living in hospital, and he thought, is this it for me? Am I going to live in a hospital for the rest of my life? And talks about how getting connected with his healthcare, having support around the social determinants of health and his health brought him to a new place, and felt like he was part of the community again, and that he regained control over his life. So I'll definitely attach that, because the middle part of the story really exemplifies that piece for him. And I have to say, we lost him 2 weeks ago. However, he was reconnected with his family and really felt like he was home, and he was in the community, and he was in charge of his life and was engaged with his healthcare. He was a beautiful human being. So I'll just end with that client story, because it takes all of that integrated support to make that happen for someone like Brian. So thank you very much.
Wonderful. Well, thank you very much for those 3 presentations. I was really struck by the fact that integrated approaches seem to be a theme throughout all of them, and the need to have that better integration between health and social services. So we'll have time for audience Q&A. So if the audience wants to get questions in the chat, feel free. But to start off the question period, a question that I had was, I know that some of the audience probably is from community-based senior services, such as senior centers or nonprofits or older adult centers, or other community-based organizations that are offering different services that might fit with this social determinants of health perspective that has been advanced, whether that be physical activity or caregiver supports or other activities. And I'm wondering how you could see these organizations being integrated into the delivery of services for older adults who have mental health needs, because often the coordination of the services seems to be a big challenge. And I'd ask the question to Deborah, but also the other panelists as well.
Yeah, and that's why we've worked really hard at kind of developing what the components are, right? Like, what is it that you need? So I think it's about pulling together partners that can provide the components together. In some partnerships, it might be 2/3 are done by this provider and 1/3 over here, or 2/4, or whatever it may be. And then we use memorandums of understanding that outline what each of us are bringing to the service or the program, and we govern it together. So we call it, I always have all these flaky terms, so we call it the together culture, right? So that we're equally kind of governing and doing the quality improvement together, and working together to that common vision. So in the beginning, it starts out with leaders coming together and kind of working all this out, and then you're bringing in implementation teams. And it's about not every service provider does everything. So we know at law, for instance, as an example, we know what our strengths are, we know where our strengths lie, but we know what we need CAMH for. And we know, and so it's about coming to the table to build a model that meets the needs, but not one service organization is going to do everything anymore. Though we call those our legacy programs back in the olden days, but now it's a really integrated approach.
Thank you very much for those comments, Deborah. And I'd be interested to know then, from the more of the healthcare perspective, Dr. Raji, do you have any comments on the integration perspective from the healthcare system? Because I know sometimes healthcare working with social or community services, there can be different perspectives and challenges.
Yeah, thank you for this question. I completely agree with Deborah. And Deborah mentioned at the beginning that we have been working together for 27 years. It's actually 17, not 27. We're not that old then. I think, but the issue is that the way we've been working together, I think that's something to keep in mind, is that it starts from the integration starts at the design phase. That when an idea comes about, that there's a certain need, there's certain question, whether it's coming from the health side, the hospital side, the clinic side, or the housing side, for example, that our team have been working on, getting the partners very early on in the discussion, so that because it becomes harder to integrate after some of the development work has happened, in either way, and becomes, it fails and creates that vicious circle kind of lack of success. So one recommendation would be to really get into this partnership, the co-design, the co-partnership, and including, an older adult who's living with mental illness, because at the end of the day, we design services, we put labels on them, but we're all serving the same person, the person that Deborah talked about at the end. So we learn a lot from understanding how we should integrate by hearing and co-designing with the person with lived experience. And starting early, I would say.
Thank you for those comments. I like that idea of co-design, and especially that person with the lived experience and centering it around them is so important. And Rosalind, I was wondering, for the CAMH policy framework, is there any recommendations around the integration piece there?
Yeah, I mean, I think there's a few, and I think Deb spoke to a lot of these amazing partnerships that see that integration on the ground. I think the other piece too is taking a step back and looking at older adults that maybe don't have more serious mental illness or serious dementia, but that are living with depression or anxiety, but still have challenges with that. And I think that in that case, there is that opportunity for integrated primary care, and to have those services provided to older adults in the community. So in, in Ontario, we have community health centers that provide these wraparound services of both mental health, physical health, and social supports. And while they're not specifically older adults focused, ensuring that older adults have access to these services, I think is really important, as well as then having the more specialized services for individuals with more serious mental illness and substance use issues.
The community health center model is one that we have a few in BC, but we see that Ontario is so far ahead of us in terms of developing those comprehensive models. So I think a lot of other parts of the country are very jealous in terms of that. Thank you. And then I see we have some questions that have come in through the chat as well. So I'm going to move over to and ask one of the chat questions. So we have a question from Diane, and she says, we work with public health across Canada to address health inequities. What are some roles that public health can play in this area of older adult mental health promotion and dementia prevention?
I can jump in, and then maybe Tarek can talk in more detail, but I think there's a huge role for public mental health here, particularly around awareness raising, looking at the modifiable risk factors for dementia that Tarek mentioned, and a lot of role around mental health promotion and healthy aging, because we didn't talk a lot about that today, but there is a huge piece for public health to focus on that. I think one of the things that would be particularly helpful for public health to focus on is, we know that there are groups of individuals, communities that are more likely, have higher risk for developing dementia, and developing public health strategies that specifically target those groups. So working with those groups on how to best reach them, and what are some of the strategies that would help improve mental health in those communities.
I mean, I think I don't have a lot to add, but in a way that, from a clinical perspective or health perspective, would be wonderful at one time that we would have dementia prevention clinics that are, available like our memory clinics now, for example. But those clinics, if they are not designed early on with inequities in mind, and so the access to those clinics and what those clinics need to be served, kind of to Rosalind's point, depending what population we're serving, who are their needs, their inequities, and the abilities to access those services would need to be addressed at the design of those services. And I think that discussion is starting to happen. I was on a panel couple of weeks ago that focuses on how to engage people with lived experience and research studies, and one of the questions was about, so who is the person with lived experience now talking to, thinking about all these modifiable risk factors? Is it the person who has dementia, or is it also the person who has all these risk factors but really don't have dementia yet? They don't have cognitive impairment. Shouldn't that be considered at this point the lived experience? And how do we serve the individual? How do we intervene? Because that is the time to intervene if we're going to change the trajectory and change those predictions that I showed in a couple of slides. We want to intervene early and design services to address the modified risk factor, and those services need to be equitable and accessible from public health perspective.
Thank you both for those answers. And that's an interesting perspective regarding who the target population should be in trying to intervene earlier. We have another question from the chat from Donna. And she asks, how do you see peer support working in the programs and services that you're involved with? So could one of you speak about the role or potential role of peer support to support older adults with mental illness or mental health?
I can start if you want. So I think we've got some more evolving to do in this area, because in our LOFT provides services to transitional age youth, adults, and seniors. So we have a full roster of peer supports in the transitional age youth, because evidence kind of definitely demonstrates why that works so well. And I think we are evolving around the older adults and seniors. And so within, for instance, site-based hubs, there's definitely peer support that's happening within the home or the site that we're providing service. And that's a lot to do with meeting with people where they're at. So there's people that receive a very high level of support and care. And then there's others that just need certain pieces and can kind of contribute to that piece. So the peer support definitely evolves out of that. And I think that concept of co-design is, as we move on to new projects, really embedding that in our process, and best practice around peer support and how to do that well. I think, it's also taking the cues from the clients that we serve. In a very brief, short example is, we're a community provider, so we want everything to be home-like, that sort of thing. And we did during COVID. CAMH came and said, we need to create some place to start to support people to leave hospital. We have this space, used to be an old hospital unit, and we designed it together and that sort of thing. But it didn't look like one of our homes. But you know what? People transition better there. So if they've been in hospital for a long time, they have a better transition. So for them as an individual, although the community thing, it's got to look like a house right away, that was overwhelming for people, and we have much more solid transition. So I think there's that design component too, that not just going by our old standby things we believe in each sector of the healthcare system, is being open to doing things in new and different ways as well.
Thank you very much for that answer. And I'd be interested in knowing then, as co-design has been mentioned as an important approach a few times in the answers, and I was wondering if you have any suggestions for resources or information if people would be interested in learning more about that process.
Do you want me to start that?
Yes, please.
Okay. So the process of Laura, the process of kind of evolving into these integrated partnerships. Yeah. Okay. So so we actually have developed a playbook yeah. So part of our and we're working with an organization in BC actually, as they've been tapped on the shoulder to do some of this work. And so we kind of refer to it as our radius work, because it isn't about just organizations like Loft doing it all, but it's about sharing the learnings and learning from others. So we've actually developed a back to home playbook, for instance, around these things. So I would say that's one thing. The Canadian Coalition for Seniors Mental Health has lots of evidence-based things, along with CAMH's framework, of course, related to social isolation. And they really are doing some amazing work around those things. And honestly, you know, it's that community and amazing hospital partners in that community. Let's just, you know, that spirit that we have, like we have to create these resources for people to live well in the community. And it's about not being afraid. I think it's about identifying what, as an organization, you're good at and what our strengths are, and then who else do we need with us. So for instance, perhaps it's a service provider organization that does personal support services. Is there an acute care hospital or a regional mental health center you could partner with? Could you partner with a community-based mental health and addiction? But you really have to let go of your stuff, right? Like there's cultures across the healthcare continuum. There just is. My husband worked at a hospital for many, many years, and there was lots of lively, you know, dinner conversations because we relate to the healthcare system differently. And so it's about letting that go at the door and having that common vision of the person that you're serving and supporting well, and just having that, you can work anything out. You know, and we have, you know, in our partnerships with CAMH, we have conversations all the time. If we bump up against something, we work it out. And it's like family, almost. Like you wouldn't know who worked for who, honestly, by the end of it, because you just have this one integrated kind of approach. So it's about just jumping in, to be honest. And I think it's about being open to new ways of doing things with the expertise and strength base that your organization has.
Maybe I'll just, like when I think of co-design, also, you know, I think also of the co-design with people with experience, and so I'll, you know, to think about, so the TDRA, so I think I mentioned at the beginning, you know, we have the Toronto Dementia Research Alliance, which is, you know, the home of it now is at CAMH. And part of the governance of TDRA is having a very robust council. It's an advisory council called the LEAP, Lived Experience Advisory Partners, who it's an advisory body to the operations of that entity, that structure, that alliance. But also people with lived experience are present that are also participating at all the operational tables and the you know, the working groups. And again, the way to have it, you know, to one suggestion again to make it happen is to engage early on discussions. So create a structure that allows people to engage, and it becomes a natural engagement like any other co-partner in a sort of working group, and not to do it after the fact. And I think because again, it becomes more meaningful, but also the engagement becomes more robust, and it becomes a culture. It becomes a way of doing things.
Yeah, thank you very much for those comments. And that really resonates with me because I have a research background. And so one of the things you hear from community a lot is researchers only go to them when they already have the study design and the funding and everything all set in stone, and then they just want them to participate. They don't invite them to be at the table earlier on when they're shaping the project. And so I can see how, as you mentioned, for the design of mental health services, having the people at the table from the beginning would be so valuable. And I see for the time, we have about 5 minutes left. So I'm going to give the audience the opportunity, if you have any last questions, to put that in the chat. And one thing that I would like to do before we end is just, Deborah had posted Brian's story. So I just want to make sure everyone has a chance to review that. So I'm just going to briefly take a moment to read that out. So from Brian's story: I could not find my place. None of these felt like home. My anxiety was real and was at its worst. I remember thinking, is this really where I'm going to end up? This is not a life, not my life. Nobody cared about me or my needs. I felt hopeless and lost all faith that things would ever get better for me. I could not go back to living independently due to my need for accessible housing with physical and mental health supports. And I spent a good 2 years living in or out of the hospital. And so, as Deborah had mentioned for Brian's story with the services that he was able to get, he was able to move out of hospital and be supported. So I think that really shows the clients that are out there who, through the benefit of integrated healthcare supports, that social determinants of health perspective are able to be supported to live with dignity and age well in place. So thank you very much for sharing that story, Deborah. I'm not sure if there's anything else you'd like to add in about Brian's story.
No, just that the ending is much happier than that statement, but I thought the way he described that really exemplifies how it feels when you're, you know, in his situation. And we're building redeveloping a site so we can serve more with this model. And he became a real ambassador for that site and was so generous with his story and time, and had the opportunity. You know, another big piece is he had the opportunity to reconnect with his family. As many individuals that are living with those challenges, they sometimes get disenfranchised and disconnected, but just the week before he passed, they were able to reconnect. And that, to me, that's what it's all about. All of this work we're doing, it's about providing good health and social services, but it really is about that stuff. So
yeah, that's a very important success, the
Yeah.
family reconnection.
Yeah.
And I see there's one last question in the Q&A, so I'll just ask that, and then I think we can close up. So the last question was, I know a lot of a community-based service in Ottawa called TCE, Total Communications Environment, in operation for many years. And Maureen was wondering if you were familiar with it, as it sounds a lot like Loft.
I can't see what's the name of it?
A Total Communications Environment in Ottawa.
No, actually, and I've had my little travels around Ottawa because my daughter was there for school, but I had not. So we'll have to look into it.
All right. Well, looks like
Thank you for that.
everyone
Yeah.
was able to learn something today.
Yeah.
All right. Excellent. Well, in that case, we're at the end of our time today. So I'd really just like to take the opportunity to thank our presenters, Roslyn, Dr. Raji, and Deborah for their very thought-provoking and insightful presentations. If you haven't had a chance to read the CAMH Aging and Mental Health Policy Framework, I would highly recommend it, and we'll send the link out to everyone afterwards. And I hope that everyone found this session very interesting and is going to be able to bring maybe some of the ideas or insights that they've gained forward in terms of their work with older adults who might be aging with mental health concerns. So thank you very much, everyone, for joining us today. And I hope everyone has an excellent rest of your day.
Thank you so much.
Take care, everyone.
Bye-bye.
Bye-bye.
Oh, and there was a comment about joining late and the recording, and we will be making the recording available to all the participants.
Thanks, Laura.
All right, take care, Fran.
Yeah, bye. Thanks to everyone. Amazing.
Thanks for me too, Laura.
All right, thanks. I'm glad you were able to join, Irv.
Yeah, I enjoyed the whole thing.
Excellent. All
Really,
right, and that.
You
Oh,
did
sorry,
a
go on.
good job.
Thank you.
take care.
Again.
All right, take care, everyone. Thank you for joining us.
Yeah,
Bye.
bye.